Good afternoon. Hello, everybody. Welcome to this session on psychedelics in mental health. My name is Vincent. I will be the chair of this session, and this session will be fascinating, I'm sure. We have high-profile, good quality speakers, also international speakers. We have two specialists of psychedelics assisted therapy. They will be giving their presentation from abroad. I think that most of us and also in the public are pretty familiar with psychedelics, but just as a quick reminder, this is an umbrella term for serotoninergic drugs. With all of them have a comparable type of mechanism of action, mode of action, and I'm sure that Patrick Martin is a pharmacologist, so he'll be describing that. So we have this category of substances. Sometimes MDMA is sometimes in that class as well, impactogen. So pharmacological mechanism is slightly different. But anyways, we are very fortunate to also have two American researchers. The first of them is Albert GARCIA-ROMEU, is a researcher at the Center for Psychedelic Research at the Johns Hopkins Hospital in Baltimore. That will be the first presentation we have. Then we'll have Matthew Johnson, is a teacher in psychiatry also at the Johns Hopkins Hospital in Baltimore. So both of them are going to talk about the use of psilocybine, which is the active ingredient in hallucinogene mushrooms. So they will talk about this in the treatment of smoking cessation and treatment of major depressive episodes and cancer-related distress. We will have an opportunity to ask questions to those speakers immediately after their speech, and then we'll be presenting the different speakers of a French-speaking round table. This is a pretty packed agenda, so I propose that we start without further ado. Maybe I'm just going to say a few words about our different speakers. Bertrand LEIBOVICI is a moderator. Patrick Martin also is the co-chair of this meeting. Zoë DUBUS is an historian of medicine, and I invite all researchers, all pharmacists, all users interested in psychedelics. And if they want to invest in research, I do invite you to be in contact with us. When I say us, this is our institution, the Society for Psychedelics, and we are always interested in sharing contacts, sharing information, so that again, well, hopefully we hope in the near future to have the possibility to have psychedelics-assisted therapies. And then we have Christian Sieur, is a psychiatrist in Carcassonne, and he will make a presentation on the concept of psychotherapy in psychedelic therapies. Well, I've just wanted to add something. There are a few copies of Respad here. Oh, Respad is a magazine. So it is available to you. You can take a copy. This edition is about psychedelics. I would like to say hello to everybody, all the technicians. I do thank them for their assistance, and I would invite you to start the first video. So my name...
And new horizons in addiction treatment. I'll be primarily focusing on psychedelics such as psilocybin and LSD. These are often thought of as drugs of abuse. However, they also have a long history of traditional use by indigenous cultures that spans hundreds or thousands of years. These classic psychedelics function as serotonin 2A receptor agonists in the brain and also bear a striking resemblance to the serotonin molecule, as you can see here. Psilocybin is a naturally occurring psychedelic found in about 200 species of mushrooms. and we currently find ourselves in a psychedelic renaissance with an increase in scientific articles and research with psilocybin and other psychedelics. Dr. Albert Hofmann first synthesized LSD in 1938 and discovered its psychoactive properties in 1943 while working at Sandoz in Switzerland. This kicked off a wave of research on LSD and other psychedelics to understand their neurochemistry and their potential as therapeutic agents. Much of this work included studying LSD as a potential treatment for alcoholism and other addictions. Some of these early studies, such as the one shown here, found no significant differences between LSD and other treatment conditions. However, other studies, such as this one published by Pankey and colleagues, found significant improvements after a single high-dose treatment with LSD compared to control conditions. Looking back, we now think that much of the variability found in the early research outcomes came from different models of psychedelic therapy or different ways of administering these drugs. Some groups used a psychedelic therapy model that attempted to produce subjective experiences with mystical or peak effects that could help change mood and behavior. Other groups used a psycholytic model with talk therapy and lower doses. Still, other groups used a chemotherapeutic approach with psychedelics as standalone medications and minimal psychological preparation. Contemporary meta-analyses have found that this early research with LSD for alcoholism treatment showed good promise and significant improvement over non-psychedelic control conditions. Other early research studied LSD treatment for opioid dependence, finding good outcomes and improved abstinence compared to non-LSD controlled treatments. However, with the adoption of psychedelics by the counterculture in the 1960s, there was significant political backlash, including prohibition of psychedelics and cannabis in the 1970s. More recently, scientists have started to ask if LSD and psilocybin have a place in medicine. That includes our research group from the Johns Hopkins Center for Psychedelic and Consciousness Research. Since 2000, we've now published a number of studies on psilocybin across a number of different participant groups, including healthy volunteers, cancer patients with depression and anxiety, people with major depression, and cigarette smokers who are seeking to quit, which I'll be speaking about today. During our drug sessions, which last about 8 hours, there are typically 2 monitors present, and participants are asked to lay on a couch, wear eye masks and headphones, listen to a program of music, and to focus their attention inward. This is what one of our psilocybin sessions might look like. And early research from our laboratory found that individuals after high-dose psilocybin experiences reported highly personally meaningful and spiritually significant experiences, not just during the drug effects, but even 2 months or more than a year later. We also found that psilocybin could increase personality openness after mystical type effects. This was consistent with models of using psychedelics as altered states of consciousness, which with targeted intervention can be used to destabilize unhealthy thinking patterns and behaviors. Using psychedelics in this way with targeted intervention can help create changes in both thoughts and emotions acutely, which can lead to persisting changes in behaviors and self-identity, including reductions in addictive behaviors. Contemporary research, for instance, has shown 2 doses of psilocybin with motivational enhancement therapy can help reduce problematic drinking for as long as 9 months afterwards. And our group has studied psilocybin in the treatment of tobacco addiction in work initiated by Dr. Matt Johnson. In an initial open-label pilot study conducted at our laboratory, 15 cigarette smokers who wanted to quit were administered 2 or 3 high doses of psilocybin in conjunction with cognitive behavioral therapy for smoking cessation. The results were very promising. 80% of our smokers were abstinent at the 6-month time point. 67% were still abstinent at the 12-month post-target quit date time point, And on average, 30 months after the target quit date, 60% were still biochemically verified as abstinent. We're currently conducting a randomized controlled trial of psilocybin-facilitated smoking cessation with a target sample of 100 participants. We've now enrolled 71 smokers. In the study, participants received cognitive behavioral therapy for smoking, and half received one high dose of psilocybin, while the other half received 8 to 10 weeks of nicotine patches. We continue to follow up with our participants through 3, 6, and 12 months after the target quit day. For some of the participants, MRI scans are occurring before and after the quit as well. Our preliminary findings in the first 44 participants who have reached the 12-month follow-up to date show superiority of a single high dose of psilocybin over the nicotine patches at 3, 6, and 12 months. However, this is still a work in progress, and we're collecting data as we speak. Data from our pilot study suggests that psychological mechanisms such as meaningfulness of the psilocybin experiences and mystical type effects, which include a sense of unity, have been correlated with changes in confidence to abstain and reductions in cravings. In their own words, participants from our pilot study describe their psilocybin experiences in this way: "It changes what I believe. We are all one and divine. The awareness that all is one and the realization I am a piece of the one's puzzle. Oneness with the universe and being forgiven." We believe these types of effects can lead to lasting change, perhaps through what I've posited as an inverse PTSD-like mechanism. Instead of a post-traumatic stress syndrome that happens after a traumatic event, it's possible that these mystical type effects or peak effects elicited by high-dose psilocybin create lasting benefit, including changes in addictive behavior. Interestingly, other drugs such as ketamine, which have shown potential in treating substance use disorders like cocaine dependence, have also shown correlation between treatment success and mystical type effects. When considering the potential mechanisms of psychedelic-assisted treatments for substance use disorders, it's important to think of both the acute psychological effects, such as a mystical experience or psychological insight that they can achieve, as well as the biological effects, such as those happening in the brain. Classic psychedelics such as psilocybin and LSD have been shown to disrupt resting state functional connectivity among key brain regions, including the default mode network. Psilocybin has also been shown to create reductions in amygdala reactivity to emotional stimuli acutely, and long-term changes in brain function lasting up to a month after a single high dose of psilocybin. Preclinical work is also showing that psychedelics can promote structural and functional neuroplasticity. Biologically, this work suggests that psilocybin or other psychedelics may change the structure and function of the brain, which can lead to behavior changes. This type of neuroplasticity-inducing effect has been shown across different species, including pigs as well as rodents. And it's possible these neuroplasticity-inducing effects are also leading to changes in behavior such as alcohol consumption. Future directions for this work include studying psilocybin and other psychedelics to treat a number of different addictive disorders, including opioid use disorder, co-occurring depression and alcohol use, cannabis dependence, cocaine dependence, and using other compounds such as mescaline or ayahuasca. Ayahuasca has already shown some preliminary evidence for success in treating different types of substance use disorders from observational research. Moving psychedelics from a research laboratory to the clinic will pose unique challenges. Trials are underway to study psilocybin as a treatment for depression as well, and this has potential for approval within the next 5 years. However, this will not be a take two and call me in the morning treatment model. This would be more like getting surgery or general anesthesia, where you'd have the drug administered in controlled settings by trained professionals with substantial preparation and follow-up. And on a celebratory note, Dr. Matt Johnson just received the first U.S. federal funding in decades to study a psychedelic for therapeutic purposes to continue our work with psilocybin-facilitated smoking cessation. Before we wrap up, I want to talk a little bit about the potential risks related to psychedelic administration because I don't want to paint an entirely rosy picture. Although these drugs are physiologically non-toxic, are not known to cause fatal overdose, they can increase blood pressure and heart rate. So individuals with heart conditions can sometimes have adverse reactions. Furthermore, they can also interact with serotonergic medications such as SSRIs or MAOIs. While classic psychedelics are not physically addictive and have no withdrawal syndrome, they do produce psychological dependence in some individuals. The relative dangers of drugs like LSD and psilocybin are generally considered very low and lower than other drugs of abuse such as alcohol, heroin, crack cocaine, or methamphetamine. However, in some individuals, hallucinogen persisting perception disorder has been observed. The incidence seems to be low, and particularly in screened individuals in controlled settings such as our research laboratory. We've not seen flashbacks associated with our research studies. However, we do know that these drugs are contraindicated in people with a personal or family history of psychotic illness or prodromal symptoms such as disordered thought or speech, delusions, unusual beliefs and behaviors, or paranoia. Survey research from our laboratory on challenging experiences with psilocybin among about 2,000 respondents showed that small percentages of respondents talked about different adverse reactions, such as putting themselves or others at risk of physical harm, behaving in physically aggressive ways, seeking medical treatment during, or seeking psychological treatment after these experiences. Very small numbers also reported adverse reactions such as enduring psychotic symptoms and attempted suicide. So this is something to keep in mind, and this is the reason we really use such careful and extensive screening and preparation before the drug is administered, as well as wraparound care and aftercare and integration after these experiences to make sure that there are no lingering after effects that could cause problems. Another relevant and emerging risk that I think it's important to note has less to do with the drug itself and more to do with the media hype around it. Increasingly, we've seen people come into these studies thinking these drugs will solve their problems or be a magic bullet. They have unrealistic expectations of these treatments, which still require a significant amount of therapeutic work and effort. Additionally, people are also using drugs from the black market when they're outside of clinical trials, which can be difficult to verify in terms of purity and dose. And sometimes these other substances that can be passed off as classic psychedelics, such as N-bomb hallucinogens, have the potential for serious adverse effects, such as hospitalization or death. So this is helpful to be aware of. In conclusion, I just want to say thanks very much for your attention, and thanks to the organizers for inviting us to present. In the future, I hope I can come visit in person. Thanks also to our funders and to our co-investigators and colleagues and all of our research staff and participants without whom this work would not have been possible. I will answer some questions now, but if you have any other questions that I don't address, please feel free to contact me at the email seen at the bottom of the slide. Thank you very much and have a good rest of your day.
Alors, en principe, on a un Zoom, n'est-ce pas, avec Monsieur
Right,
Albert.
so I think that Albert GARCIA-ROMEU is available here on Zoom. Hi, to answer a question. Hi there. So I suppose that you, yes, I'm interpreted in English directly. Can you hear me in English? Can you hear me in English, sir? Can you please confirm that you hear the English interpretation? Hello?
Hi, can you hear
Hello?
us?
Apparently.
I can hear you.
Okay, great.
Okay, so thank you very much, Albert GARCIA-ROMEU, for being with us today. I am really convinced that the topic is so fascinating, and thank you very much. And I think we have a short time, so maybe we will take the question right now from the room. Si vous avez des questions.
So if you have questions, so should I talk French, speak English or French? Yeah, but you have an interpretation.
I just would like to know something. You made a clinical trial with psilocybin and tobacco 5 years ago on a small number of patients. Why did you stop then? Why didn't you continue on this way? Very important.
Thank you. We actually did continue that work, and we have now initiated a larger randomized controlled trial with 100 patients, and that is in process now. So that is 70 people enrolled, and we hope to finish next year.
Alors, s'il vous plaît.
Hi. Hi, Albert. This is Anton Gomez Escolar from Spain. I'm preparing a study on psilocybin for the treatment of polydrug use. And I was wondering, how did you approach this serotonergic risk when it comes to people that is taking antidepressants? Do you exclude them from the study? Is that exclusion criteria, or do you suggest tampering off them before accessing the psilocybin treatment?
We usually would exclude people from the study if they're on a serotonin medication like SSRI or MAOI. If they're on an antipsychotic, then usually that would be exclusionary as well. For some people who are on serotonergic medications, but they don't think that they're going to have any problems tapering off, we allow those people to do so with the supervision of their doctor, but then they can come back and complete the screening and enroll in the study.
Thank you.
D'autres questions?
Are there other questions? That question was very interesting from a pharmaceutical point of view, pharmacological point of view. Alex?
Thank you. You spoke of crack cocaine. Do you have an experience in that type of patients?
So we have not studied cocaine dependence or crack cocaine use with psychedelic treatments, but my colleague, Dr. Peter Hendricks, who is at the University of Alabama in Birmingham, is in the middle of doing this pilot study with psilocybin-assisted treatment for people who use cocaine, including crack cocaine.
D'autres questions?
Are there other questions? So the winner is 1 point to.
Thank you very much. And now I think we are going to hear your colleague, Matthew Johnson. Thanks a lot.
Thank you.
Thank you.
Hello. Professor at Johns Hopkins University in Baltimore, Maryland, in the United States. I'd really like to thank the meeting organizers for inviting me and my colleague, Dr. GARCIA-ROMEU, for speaking at this meeting on psychedelic research. I've been conducting research with psychedelics since 2004, so during the last 17 years, including work in healthy normals as well as several therapeutic populations. And that's part of what I'm going to describe today. So I'll go ahead and share my screen at this point to move ahead with my talk. Okay. Psilocybin in the treatment of major depressive disorder and cancer-related stress. First, by way of disclosure, I'd like to just show you on the screen here several companies that I advise as a scientific advisor regarding the development of psychedelics or related compounds as medicines. Most of what I'm going to describe is about psilocybin. It's the active agent in over 200 species of mushrooms, so-called magic mushrooms. It's a classic psychedelic, meaning it serves as an agonist at the serotonin 2A receptor, and that puts it in the same pharmacological class as LSD, mescaline, and dimethyltryptamine. Psilocybin mushrooms have a absolutely historical and prehistorical record of use. I'm showing you artifacts on the left and in the center from Central and South America, dating back to several hundred to a few thousand years ago. On the right panel, I'm showing you a cave painting from Algeria, estimated to date around 9,000 years ago. And this is arguable but highly suggestive of sacramental use of these psilocybin-containing mushrooms. You see these little figures with their heads turned into mushrooms, and they're dancing around holding mushrooms in their hands. So then we'll fast forward several millennia to the 1940s through the 1970s. This was the early heyday of research, human research with psychedelics. They were intensely investigated as research tools and as therapeutics. And the most promising therapeutic findings were using LSD in the treatment of alcoholism and LSD in the treatment of cancer-related distress in terminal cancer patients. And then there were the dark ages. Despite some initial promising therapeutic findings, the research in humans with psychedelics stopped for a few decades. This was for a number of reasons. Number one, there were some very real casualties due to the reckless use of psychedelics when they became popular in the 1960s and early 70s, and also the association with the counterculture at the time really stigmatized the research, and the media failed to distinguish the safety profile that you got from young people using these drugs recklessly versus highly controlled medical research. And as part of this, the United States and most other major countries in the world highly restricted psilocybin and the other classical psychedelics. Well, if those were the dark ages, these are the days of enlightenment. I'm showing you the scientific papers published each year with psychedelic or the synonym hallucinogen in the title. And you can see dating back for a couple of decades that there were 5, 10, 20 papers a year, pretty steady baseline. And then you saw a dramatic uptick in the early 2000s. And this exponential-like increase has been prompted by the really promising therapeutic findings with psychedelics. And I'm going to show you some of those data today. So one focus I'm going to discuss is psilocybin in the treatment of major depressive disorder. About 7% of adults in the United States have had a major depressive episode in 2017, with 64% of those having severe impairment. Most patients do not experience complete resolution of symptoms with existing antidepressants. So this is an area where we certainly need novel solutions. So most of the data so far regarding depression with psilocybin and other psychedelics is in the context of depression within cancer patients. And so there have been 3 double-blind studies looking at psilocybin in the treatment of cancer-related depression and anxiety. The first one preceded our work with cancer patients. This was a small open label, it was a double-blind study, not open label, but it was a small pilot study with 12 advanced stage cancer patients conducted by Charlie Grove at UCLA in the United States. It was double-blind, and they used a fairly moderate dose, about half the dose of psilocybin that we ended up using in our cancer treatment work. And to be clear about this cancer, work. The goal here is not to treat the cancer itself, but to treat the psychiatric distress that often accompanies a cancer diagnosis. And in this study, as you can see in some of the figures I'm showing you, they found long-standing decreases in both anxiety and depression. That prompted our work a few years later. This was a much larger study with 51 participants. They all had life-threatening cancer. It wasn't necessarily terminal. For some people, it was terminal, but it was all life-threatening. About a third of participants met criteria for one of the DSM disorders associated with depressive symptoms. About a third met criteria for a DSM disorder associated with anxiety primarily. And about a third met criteria for DSM disorders spanning both depressive and anxiety symptoms. It was a within subject crossover design, so everyone served as their own control. Everyone received a high dose of psilocybin, which was meant to be the real intervention, versus a trivial dose or a low dose of psilocybin, really meant to serve as an active placebo. After screening and baseline and preparation, people were randomized to either receive the high dose first and then the low dose 5 weeks later, or to receive the following order, low dose first, followed 5 weeks later by the high dose. And here I'm showing you our major outcomes, the Hamilton Depression and Anxiety inventories. People came in at severe levels in both randomized groups. At baseline, you would expect them to, on average, to be about the same. And they are, both the red and the blue groups, the low and the high dose first groups. And at post 1, that's 5 weeks after the first psilocybin session. At that point, the red group has now received the high dose 5 weeks ago. And you see there dramatic reductions from the clinically severe range in the 20s to the normal range of the scale, quite a dramatic reduction into the 5 to 10 range of the scale. Also saw a sizable reduction in the trivial or low dose group, the blue group, likely due to the placebo effect, the expectation effect, as well as the rapport building that happens in preparation for these sessions. Nonetheless, not nearly as large as what you saw in the high dose group. And then 5 weeks after that, at post 2, that's 5 weeks after the second session. So not everyone has had the high dose, real deal dose administration, whether that was 5 or 10 weeks ago. And so now you can see both groups have that very low level on average of symptom reduction. So both the blue and the red group are now at that very low level of suffering. And that's astonishing enough for a single dose to last 5 or 10 weeks. But we also found that those reductions were virtually unchanged when we probed 6 months later. So now I'm going to introduce something about the nature of the subjective experience. One of the things that we found in a lot of our research to be a meaningful measure is this measure of mystical experience during the session. So we measure this before they go home, but after the drug effects are worn off. Mystical experience sounds a little new agey, a little religious, for example, but it in fact is not. It is a psychological construct that is nominally divorced from any supernatural or religious thinking. It dates back to William James, the great psychologist 100 years ago, who noted that across different cultures and across different languages and throughout the centuries that human beings having extraordinary experiences, whether it's prompted by fasting or a near-death experience or prayer or sometimes just out of the blue, sometimes these extraordinary human experiences share remarkable similarities. And those similarities being a sense of unity expressed in different ways, but feeling at one with humanity, one with the universe, a positive mood, a transcendence of time and space, and a sense of ineffability, or that the experience is beyond words. And so we developed a scale to assess mystical experience in the context of an acute drug administration study, the MEQ30. But this is shown pretty meaningful. We found that the level of reduction in our cancer patients 6 months later, the level of depression and anxiety reduction was statistically correlated to the level of mystical experience as measured on their session day. Not only that, but that relationship held up above and beyond statistically controlling for ratings of drug strength. So it's not just how strong this drug effect is. It's not about just getting hit over the head with a strong drug effect. There seems to be something about the psychological nature of the experience that's important in these sessions. So the next study that was published at the same time as ours, slightly smaller study by colleagues at New York University, 29 patients, very similar study, but enough differences to make it really robust in that they found very similar results. So they used niacin as the active placebo rather than a low dose of psilocybin. Nonetheless, they found large reductions in depression and anxiety that were lasting because of this a high dose of psilocybin. So very consistent with our results. Now moving outside of depression, of cancer-related depression and anxiety, now we're moving into just the treatment of major depressive disorder, so depression outside of cancer patients. The first work in that area was published by colleagues at Imperial College London in 2016. Their initial studies was with 12 patients. It was an open label study, so not blinded, but they found, similar to the work with cancer patients, that in this measure, the QIDS, this measure of depression, people came in at the clinically distressing level of symptom severity, and psilocybin prompted large statistical reductions in depression that held up to at least 3 months after that administration. Our group then late last year published the first randomized study of psilocybin in the treatment of major depressive disorder, again, outside of cancer patients. And these were 27 patients. This was a randomized waitlist control where people were randomized to receive 2 open label sessions, either relatively immediately after the preparation, or to wait in another group that had to wait. The other group was randomized to wait a couple of months before starting with that whole process. And we used around the same doses we've used in our previous studies, a moderate and then to a high dose. And this is essentially what I just described to you. People are, after screening, randomized into the immediate or delayed treatment group. And then you have our assessment of symptoms and our administration of the psilocybin sessions, either in the immediate or in the delayed timing. Participants here, a fairly educated, highly educated sample, mean age 40 years, mostly female. They had, a long history of depression. A mean duration of current episode was 24 months. So these were not lightweights. These people really had convincing depression. Mean duration of illness, 22 years. We did find in these sessions that people indeed scored high on mystical experience, as I'm showing you for the 2 sessions. And here are the key results. This is on a version of the Hamilton Depression Inventory. Very similar to the previous studies that I showed you. People came in at baseline at a relatively severe level of depressive symptoms. The immediate treatment group, 5 weeks, shows this is after they have received their 2 psilocybin sessions, and you see a dramatic reduction into the normal range of the scale on average. And that reduction appeared to be stable across several weeks. You saw no change in the delayed treatment group. So that blue group on the screen right now, those are people who have not received psilocybin yet. They're simply waiting for the treatment. What I'm not showing you here is that after that waiting period, the delayed group then received psilocybin. They were crossed over to psilocybin. And at that point, we saw reductions that were similar in magnitude as the immediate treatment group. So a similar reduction in depression after the delayed group finally received their psilocybin. And I'm showing you both the delayed and the immediate group here in aggregate, because those reductions were very similar across those 2 groups, showing you those data together, showing you these very large statistical effect size reductions in depression. And this was a clinically significant response. So I'm showing you the percentage of participants who had a clinically significant response, upper 60s, lower 70% at the various time points. And remission, this is showing you at the bottom, remission is referring to the participants that are brought down into the lower range of the scale that's not indicative of any disorder. So a majority of participants at all time points after they had received treatment were in remission. So very promising results. Here I'm showing you very similar results with anxiety. Although we focused on depression in terms of recruitment, these patients often also have anxiety. And so we saw in the immediate treatment group, the reduction in anxiety and a trend towards an increase rather than a decrease in the people that were randomized just to wait. So depression substantially decreased the day after the first dose. So that's really important to note. Much like ketamine, which has been viewed as a breakthrough in the treatment of depression, it appears that psilocybin has immediately acting results. So this is in stark contrast to the typical SSRIs and other typical antidepressants, often that take 2, 3, 4 weeks for the therapeutic effects to kick in. We found that treatment did not exacerbate depression in any participants in this study, so it didn't make anyone worse in this study. However, it didn't help everyone. 2 participants had little to no therapeutic response, so it's a minority, but some people were not helped. And we also, like our other studies in humans with psilocybin to date, there were no serious adverse events related to psilocybin. Now, to be clear, there is sometimes anxiety during sessions, which is all of these sessions are monitored in our clinic. The person is with 2 individuals, 2 guides who are there with them, who they've developed a therapeutic relationship with and that they've prepared with for the session. And those people are there to reassure them. And that interpersonal reassurance goes a long way. So although you have some adverse events such as anxiety and some modest elevations in blood pressure and pulse during the session, none of these AEs were serious in magnitude. So in conclusion, we've seen promising results for large reductions in depression and related symptoms in a variety of populations, not only cancer patients as seen in 3 different double-blind studies, but also across multiple laboratories in the treatment of depression outside of cancer. Treatment with small number of sessions with long-term benefits, it's a different psychiatric paradigm. So, our various treatment studies have only given 1, 2, or 3 doses of psilocybin under these treatment conditions. And so it's very different than chronically treating the symptoms of a disorder. And I think that's because oftentimes people in these psychedelic sessions, they really deal with their own psychology and have some psychological resolution in the disorders that have been causing them distress. So it's less like the treatment of symptoms and more like they're getting to the roots of the psychological disorder. And my colleague Sandeep Nayak and I recently wrote a paper about this, really describing psychedelic therapy as this novel paradigm in which psychotherapeutic process itself is amplified. In fact, we argue that the common factors that have been shown to predict successful psychotherapy in a more powerful fashion than even knowing the school of thought or the particular method of the therapist. It's these common factors which include the degree of rapport, the sense of plugging into, of being a part of a system with a path towards healing. These types of common factors, we argue, are strongly amplified in psychedelic therapy. So psychedelic therapy really is the biological facilitation by the psychedelic drug of psychotherapeutic process to allow that healing to occur. the most advanced and robust research in this area in terms of the treatment of depression is in the context of cancer patients. And so there have been 3 double-blind studies using psilocybin in the treatment of cancer patients. However, no current studies that I'm aware of are currently running with this. So this has really been a thread that's been left dangling. I think there have been some research groups that have expressed interest in picking up on this research, but this is a really special population. It seems to be especially effective in these cancer patients. So I really hope some funding can be made available to continue that work treating these cancer patients. No blinded studies published on major depressive disorders. That's actually not true. There's been one recent blinded study published out of Imperial College London that found a similar response profile to escitalopram, a typical antidepressant. It was a double dummy design where they found reductions in both groups with a trend for larger reductions in depression in the psilocybin group. But we certainly need an increased amount of blinded research looking at psilocybin in the treatment of major depressive disorder. So with that, I just want to acknowledge a large number of folks. Al Garcia, who you'll be hearing with in this conference, but also Roland Griffiths, Mary Cosimano, Fred Barrett, some of the heavy hitters, also Sandeep Nayak, who I mentioned. Too many others to mention, but also want to thank funding from the Cohen Foundation, from the Tim Ferriss Collaborative, from the Hefter Research Institute, a large number of philanthropic organizations that have supported our research over the years. And you can find out more about our research at hopkinspsychedelic.org. But with that, that's my presentation, and thank you very much.
Il n'est pas encore là, Matthew Johnson. Je peux dire un tout petit
Matthew Johnson, is he here? Can I say something?
J'enfonce peut-être une porte largement ouverte.
Maybe you all know that, but we just heard two students of someone who played a key role in the rebirth, the psychedelic rebirth, Roland Griffiths, and many of the studies we've heard about were under his control. And if we have time, I will tell you more later. Oh, Matthew Johnson is with us. So are there any questions for him? Yes.
You observe a very long action of the psilocybin and very favorable. Is it because the psilocybin is always present all along the duration of the treatment? Or is it because you have change in the brain of the patient?
I'm not quite sure I understand. Maybe you could repeat?
Can I tell you?
Yes,
because
sure.
I've understood the question.
You observe a very long action of your product. And is it because the compound is always present all along the treatment? Or because the brain of the patient has somewhat changed?
Yeah, I understand. Thank you.
Exactly.
Great question. The drug is metabolized well within a day. So the persisting positive effects are not due to any present drug level. Presumably, there's a biological change that is lasting. And there's a lot of hypotheses, but we don't have really solid evidence. There's some evidence. My colleague presented a bit of that, some evidence in terms of changed brain function a month later, but presumably there's even changed brain function 6 months or a year later when we're still seeing therapeutic effects. We know that there are psychological changes. But yeah, we think this drug works in a different way, in which the drug opens up a window of flexibility, and a therapy can be more effective during that change. Behavioral change is more effective during that time.
It could be interesting to use IRM to observe the patient brain.
You
Eventual
mean
change.
fMRI, I guess, like
Yeah,
imagery.
we are in the smoking cessation work, examining fMRI before and after. So hopefully we'll have an answer to that when we complete our current study, if there is a long-term change in brain function.
Thank you.
Thank you.
Good morning, Matthew. This is Anton Gomez Escolar from Spain. I'm starting a study now in psilocybin for the treatment of polydrug use. And first of all, I wanted to congratulate you for the grant, the NIDA grant. Really amazing
Thank
news.
you.
And ask you regarding what is your opinion on the use of active placebos when blinding work with psychedelics? Because you mentioned before that you were using a low dose. I'm not sure if as a placebo or as a way to prepare the patient for the experience, for the higher dose experience. But I think it's quite difficult to find good ways to blind this kind of research. I mean, the effects are so apparent and so powerful that it's very difficult still to find a way to do it. So what's your opinion on this? Do you think that the use of low doses of psychedelics is good enough for blinding this kind of studies?
It's a challenge. I currently have a review paper that we're working on that's exploring this area in the history of psychedelic work. There's no perfect solution to this. The use of the low dose in the cancer study was not intended to mimic the effects of the drug, of the high dose condition, but rather to control for the instructional set. In other words, we could truthfully tell everyone that in your session, you'll receive some dose of psilocybin, but we simply didn't tell the participants what dose that was going to be. So in fact, they thought they could have received 2 high dose sessions or 1 high dose session and 1 low dose session. So in fact, everyone received 1 high dose and 1 low dose. So it was a way to just obscure the drug, well, truthfully obscure, we didn't lie, but we obscured the fact that it was going to be 1 high dose and 1 low dose. So it's not a perfect solution. The concern about low doses, if you got the dose high enough, that might actually work for enough people. And in fact, that's the lesson that the MAPS group has learned working with MDMA, you're probably aware. They actually found the optimal dose was actually closer to what they were originally looking at as an active control. And it was lower than what they initially thought the therapeutic dose would be. So we have in previous research used a high dose of a stimulant. That of course has some limitations. It's addictive. It's going to have a stronger cardiovascular, more dangerous cardiovascular response than psilocybin itself. I think a really good idea for future research is to use a compound like oral THC as an active control. But yeah, we need more innovation. We need more studies to do a better job at assessing their blind. In other words, reporting, whether participants, what their guess was in the study. So, we need to do a better job in the research that we've done in the past, and keep exploring solutions to this. So hopefully that helps. And I'm really glad to hear you're starting that study. So I'm hoping to hear more about it. Wish you luck.
Y a-t-il d'autres questions? En attendant, I would like to ask a question too. Hi, I'm Matthew Johnson. Thank you very much again. I was wondering if do you think in the future that we could imagine therapeutic sessions with several patients being given psilocybin in the same room instead of giving the substance one patient after one patient? I mean, I think it would be more maybe I don't find the exact word, but more easy to treat several people in the same time. I'd like you to elaborate on this, please.
I agree, and we need more work like that. It's actually not, the modern research has not done that yet. Administer it to a group, but in fact, this happens, all of the time. It's the norm in shamanic use and in different forms of religious use, whether it's the Native American Church or the UDV, or just informal circles of people that use psychedelics for sacramental intent. Group sessions are very, very common. So I think, and this is what we've done so far with individual treatment is a very expensive treatment model. So there are some concerns about that's going to limit dissemination. Is this going to be, if it's approved as a medicine, is it going to be widely adopted? Are insurance companies here in the United States, are government payer, government insurance systems going to choose to pay for it, even if it's approved, if there are cheaper models out there? So group sessions is a good way to explore making this cheaper. Again, not just for the point of making it cheaper, but making it cheaper means it could perhaps be have greater dissemination and help more people. But that work needs to be done very cautiously. There's additional concerns. For example, one, anxiety experience might spread to the different participants. So there's going to be some learning involved there. But there is a science on conducting group psychotherapy outside of psychedelics. So there are many lessons that clinical psychologists have learned about how to conduct group therapy well. And what we need to do is incorporate those lessons into studies that explore this question, with strong safety protocols in place. And then we'll learn something through that research about how to potentially do that safely. But I agree that's a very needed direction in the future.
Bon, mais thank you again, Matthew Johnson, and good work for the next years.
Thank you.
Now, I'm not sure who's going to be the next speaker. Now, we are going to listen to Patrick Martin. He's a pharmacologist in a psychiatric ward in Paris. He's going to talk about pharmacology of psychedelics and other hallucinogens. Hello, good afternoon to everybody. First of all, I would like to thank all the organizing team of this conference, especially Jean-Pierre and Archives, and they were very nice to invite me. So what I'm going to talk about this afternoon, if the remote control works, I'm going to talk about pharmacology and pharmacology of those molecules, but this with a rather, maybe a more provocative take on this question. Those molecules exist for many centuries. From a pharmacology point of view, they have a unique mode of action. they would act on the serotoninergic mechanisms. And now with the advances in neurosciences, we may have a different take on this, a different approach. So I'll be conducting a sort of inventory of all the molecules, and I'll try also to discuss the different mechanisms of action on some disorders, some symptoms, and I'll try to shed potentially a different light and talk not so much by category of drug, but rather by dimension or type of disorders. Okay. Oh, the remote control is very sensitive. Okay, can you please go back? So the first avenue here is that when we look at the current indications of those drugs, the same psychedelic molecules have an impact on those disorders on disorders that have different underlying biological reasons. So is it a sort of panacea? Is it something which is really having an impact on the disorders or some symptoms? So from a pharmacodynamic point of view, we may wonder what are the effects on the symptoms. And also there are some psychological effects. So are those molecules going to bring to the front other things that are underlying? And so we need to have a customized approach. We need to have a personalized medicine, and this is a very fashionable approach. And maybe this is just, again, a very specific momentum. You can see my background here is inspired from The Matrix, the film. And somehow maybe we are inscribed in a matrix, and you would have a reality, but a reality that is different from the reality as we experience it on a daily basis. And maybe those magic pills will help us get into that different reality. But this is maybe what our patients experience. So if we put ourselves in their shoes, maybe this is what they experience. So we have a clinical classification of hallucinogenic drugs. We have the psychedelics, the dissociative, and the ones inducing delirium. I'm sure that my colleagues will talk about semantics, and maybe there are some confusion here about the words. One of the main families are tryptamines with an indole nucleus, then subdivided in 3 big groups, so chemical groups with big names and big words. So this is, so you do have the simple indolkinamines, the complex indolkinamines, and all the algolins, and this makes the bridge to LSD. So the first group of tryptamines are the simple indolalkamines. This is what you find in a type of mushroom that you find in Central America. This is similar to psilocybin. So it is a prodrug, a product activating psilocybin. And so the metabolite of this alkaloid is psilocin to be more precise. So there's an impact on serotoninergic receptors, of which the receptor 5-HT1-2A, and they have an antidepressant role. And if we were to draw a parallel, they are not agonist to the serotonin. This is not what provides the antidepressant effect, it's rather the opposite. So this, of course, is a source of problems. So there's not a single mechanism, but this is really, there are also many questions. In the last years, we have explained the neurotrophic effect. You also have dimethyltryptamine, DMT, first endogenous human endoalkaloid. It is present in the hypophysis. This is close to melatonin. There's also an indolic nucleus. This DMT molecule is present in many plants. We find it in the composition of ayahuasca, and it is synthesized chemically. And of course, the action is again a serotoninergic type of action. So you have the intrinsic activity, which is going to bind to one receptor. Then you have the affinity of those molecules to some other receptors. And affinity does not necessarily translate in a clinical impact. The interest of this molecule has other impacts on neuroadrenergic receptors, on the serotonin transporter as well. And you'll see that for all molecules, there's an interest of all those types of molecules is that they also have an impact on the signaling, neurotrophic signaling pathways. Now, this joint signaling pathway now, amongst the indole-alkylamine complex, you have ibogaine and harmaline that you find in the human brain. You also have a different type of potential mechanism of action, dopaminergic systems, and also involved in glutaminergic system. And this research demonstrated that a number of those molecules have an impact on this pathway. This you find in neurotrophic substances, and the interest of this molecule was also shown on a number of opiate receptors like kappa. Next slide, please. Talking about Algolins and derivatives, this is the molecule which was the most studied, derived from a parasite, from a specific mushroom. And the consequences in humans are known for a long time, since the Middle Ages. And researchers from Sanders have studied this molecule in order to find a vasoconstrictive molecule for migraines and Parkinson's disease.
Le 25e, LSD 25, c'est pour le 25e dérivé qui a été donc synthétisé et pour lequel on s'est focalisé. Diapositive suivante.
And so we focused very much on this one, on tryptamines. So the difference between serotonin and that is, again, they have the same nucleus, they have common structures, and the entire family has an impact on the serotonergic pathway, but not only. LSD is 100 times more active biologically than psilocybin and 4,000 times more than mescaline. Next slide, please. Now, the active molecule is enantiomer. There are different mechanisms of action. So there is an agonist impact on a high number of receptors. And this was at the origin of an hypophysis in case of schizophrenia, and the role in the impact of other molecules. There is an impact on a high number of serotonin receptors. You see the complexity of all those receptors, and the effects are different depending on the brain structure and depending on where the receptors are placed. With 5-HT1 receptors in the hippocampus are going to stimulate serotonin, and you are going to have antagonist impacts on other parts of the brain. So again, it's highly complex in terms of mode of action, type of receptors, and again, depending on the structure in which we measure this impact. But also an affinity for the alpha-adrenergic receptor, on the glutamatergic, and on the signaling pathways as well. A few words on tryptamines. There are a number of emerging tryptamines were synthesized, and they demonstrate roughly the same effects, but we are quicker at synthesizing those molecules than finding their mechanism of action. However, we may think that those molecules are going to act on the same serotoninergic receptors. The second big groups of phenylethylamines refer to those that substitute amphetamines. Alexander Schulding, an American pharmacologist, was able to synthesize more than 200 molecules from that group. And he wrote a book that I read and loved, which was very famous back in his days. And he synthesized ecstasy, MDMA, which is also a molecule of that group, and they have an impact on the serotonin and pathways and others. So very quickly here, you have new synthetic products, new psychoactive substances with a substitution of a nucleus. So derived from amphetamines. You do have the derivative of methylphenidate, and the mode of action are different. Those molecules are very close, but the mechanism of actions are very different. Now, in the same group of molecules of, you have the substituted phenylethylamine, you find mescaline, that you find in cactuses. The most famous is Apelliot. And the mechanism of action also is on the serotoninergic receptors, especially in the prefrontal cortex. A number of derivatives were also synthesized. There are new properties that we need to check the impact. There are other synthesis products that appear on the market, like 2-CBEE, and the mechanism of action is again similar to the others. Now, a last group, which is a mixed group. Those are not molecules that are quite hallucinogenous, but are more dissociative. And depending on the group, there are properties that are dissociative and hallucinogenous. So in that group, you have PCP, ketamine, and methoxetamine. And so they are dissociative, but also provide hallucinations. A word on ketamine, which was synthesized in the 50s. They were looking for analgesic drugs, and they found molecules CI400 and CI400 and PCP that had this impact and provided hallucination. 200 derivatives were studied and simplified from PCB to only CAPE1, ketamine. Ketamine is an anesthetic drug, and at a sub-anesthetic dose, it provides hallucination. The metabolism is, of course, of interest because there's an active metabolite. So it can be synthesized at 80% in this metabolite, which explains that the management of this molecule, there are genetic factors depending on the speed of metabolism. This molecule was widely studied with a glutamatergic mechanism of action. It inhibits the MNDA receptors in the prefrontal cortex and in the hippocampus. It's also the inhibitor of a number of dopaminergic receptors, and there are also regulatory effects on other systems in combination with GABAergic systems. Ketamine is also an agonist of 5-HT2 agonists, and we may think that this explains some of the hallucination. It also inhibits the recapture of dopamine. And also, it is involved, there are a number of neurotrophic factors, and this explains, at least partially, what we see here. You have on that slide the hypothesis and the potential antidepressant effect of this molecule. So this is no longer a monoaminergic effect of antidepressant, but this is the impact on glutamatergic effects. So there is a cascade of effects from a biological point of view, which translate in an increase of neurogenesis, and that would have an antidepressant effect. But from a point of view, this has more to do with the type of dimension, because when you increase neurogenesis, this is not what is going to provide an antidepressant effect, and this is not what is going to help cure a depressive patient. Now, next slide. Okay, so next slide. Now, before I conclude, if we try to have a representation of the different types of drugs with a neurobiologic action, it's complex because each group of molecules do not have a precise effect, but each effect, they also have retrocontrols on the different pathways, on the 5-HT2, on the 5-HT1. When you stimulate those receptors, the 5-HT2, you also have a retrocontrol on other receptors. And then you have other mechanisms of action, which are less known, less conventional than other psychotropic drugs, and they may have a role in the different disorders and indications that exist at the time being. Next slide. My conclusion, in this entire approach, there's a parameter that we need to take into account. In the 16th century, what is important is the dose. So any substance can be a poison. Nothing is without poison. The only thing which does or does not create a poison is the dose. Thank you very much for your attention. Other questions for the distinguished speaker? I have one question. What about the cholinergic drugs? I never seen them discussed for their therapeutic interests. So I would like to seize this opportunity to ask you. So they do exist, but there are so many side effects that I don't think that they are useful from a therapeutic point of view. And I don't think this is a route that should be pursued. Ketamine is used as a drug very frequently. And I would like to add something on ketamine. I find it extremely interesting. To my knowledge, 4 times China asked for ketamine to be classified in international conventions, and the Commission on Drugs at the UN was in agreement. Only the WHO had to weigh in because of the anesthetic properties of ketamine, especially in poorer countries. And so the WHO vetoed this classification. And I think that if it had been classified as a drug, an illicit drug, then I think we would have, tried to demonstrate quicker the antidepressant properties. Right, if there are no further questions, I think we can give a nice round of applause to Mr. Martin. And we're going to transition to the next presentation, a presentation on the history of medicine, thanks to a doctor in medicine. You have the floor, Zoe. Hello, everybody. I would like to thank the organizers of this conference for the invitation. It's always a pleasure as an historian to present my research, all the more so as when I started my PhD some 10 years ago, the question of psychedelics was almost not known at all in the field of medicine. And we see a lot of interest in the last 2 years, more and more interest. So it's fascinating for me as an historian to see this gain in interest. So I'm going to talk to you about the moment when therapy started with those drugs, and we're going to see which techniques were implemented in those days, in between the 50s and the 70s, to help with psychotherapy. So we've seen that already in the previous presentation. Albert Hofmann in Switzerland discovered the effect of LSD by chance in 1943, and as of 1947, Sandoz is the lab which produced LSD and is going to send on request LSD to a number of for therapeutic use, GPs, but also pediatricians and psychologists and psychiatrists, etc., for a better understanding of the brain. As of 1950, Bush and Johnson are going to start the hypothesis that LSD, because of the potential to have material emerge, come to conscience, could improve the psychotherapeutic process. So a number of therapists are going to advocate for that. But LSD has been used in a wide number of indications. You have the most important here. So in this period of time,
c'est un des médicaments les plus étudiés au monde. Alors, le domaine dans lequel il est le plus employé, c'est la psychiatrie, qui, jusqu'aux années 50, reposait sur 2 modèles thérapeutiques. On avait d'un côté les thérapies de choc, avec par exemple les comas insuliniques, les électrochocs, la narcoanalyse, les lobotomies, etc., qui existaient depuis les années 30. Et puis, de l'autre côté, la psychanalyse. Alors, les années 50 vont bouleverser ce paradigme-là en ouvrant une 3e voie, qui est celle de la psychopharmacologie, grâce à 2 types de substances très différentes, les neuroleptiques, dont on ne parlera pas aujourd'hui, et puis les psychédéliques. Alors, progressivement, il y a des nouvelles méthodes qui vont être proposées pour mener les psychothérapies assistées au LSD. Il y a certains thérapeutes qui vont observer qu'avec un accompagnement spécifique, que je vais décrire juste après, la substance permettait d'accélérer effectivement la psychothérapie. Alors, les séances visaient à faire revivre aux patients des souvenirs, à leur permettre d'avoir ce que les médecins appelaient des révélations intuitives sur eux-mêmes, sur leurs relations, sur le monde en général. Tout ça sur fond de forte réduction de l'anxiété qui était là aussi produite par le LSD. Alors, le médicament permettait d'être plus à même d'exprimer ses émotions et de les intégrer. Et contrairement aux autres méthodes qui existaient jusqu'alors, comme par exemple la narcoanalyse, les patients y restaient conscients pendant la séance et donc ils gardaient en mémoire tout ce qui s'était passé, ce qui permettait ensuite, dans d'autres séances ultérieures, d'intégrer tous les éléments qui avaient émergé dans la séance dans un but thérapeutique. Alors à cette époque, la communauté scientifique, elle attend des équipes qui veulent travailler avec le LSD, qu'ils aient une expérience personnelle et répétée de la substance, parce qu'on estime à ce moment-là que les effets psychédéliques sont ineffables, donc ça veut dire que le langage n'est pas capable de retranscrire vraiment l'expérience. Et donc, pour vraiment être des experts, il va falloir en prendre soi-même. Donc, on retrouve dans la presse médicale tout un tas de comptes rendus d'expériences. C'est toujours assez marrant de les voir de notre point de vue aujourd'hui. Je vous en ai mis un que j'aime bien, qui est celui de Henri Gastaud, qui est neurologue à l'INSERM à Marseille et qui est un des premiers en France à étudier le LSD. Alors, il commence à expliquer que les membres de son équipe qui se sont prêtés à l'expérience sont d'humeur épanouie, euphorique, décontractée. Et puis après, il nous dit qu'il y en a un d'entre eux qui d'habitude est très réservé, qui se met à faire des blagues, à déranger son patron, etc. Donc, ce qui caractérise les expériences qui sont faites par des membres du corps médical en général, ce n'est pas toujours le cas, mais en général, c'est que c'est des expériences qui sont positives, euphoriques, voire vraiment émerveillées. Alors, ce n'est pas du tout le cas de leurs patients. Je vous ai mis ici un nuage de mots que j'ai fait à partir des comptes rendus d'expérience de Jean Delay à l'hôpital Sainte-Anne avec ses patientes. Et là, vous voyez que ce qui domine, c'est plutôt la peur, le sentiment d'être en train de devenir folle ou d'être en train de mourir. Donc, c'est des expériences qui sont difficiles. C'est ce que souligne son confrère de l'époque, Henri Hay, qui est l'autre très grand psychiatre de cette époque, et qui dit « Les sujets de Delay et Benda c'est l'interne de Delay, étaient comme saturés d'angoisse et faisaient peu allusion à l'état d'euphorie qui, lui, était rapporté par les thérapeutes qui faisaient des auto-expérimentations. » Alors, le fait est que Henri Hay, il mène lui aussi des expériences avec ses patientes, avec le LSD, et comme vous pouvez le voir, ça se passe pas très bien non plus. Il y en a qui hurlent, qui pleurent, qui se jettent par terre pendant des heures. Bref, c'est des expériences à nouveau qui sont difficiles et qui aggravent en général le tableau clinique. Donc, on voit qu'il y a une grande dichotomie.
We see a dichotomy in the medical profession and among the patients. So there are some in the Anglo-Saxon do this finding when they have a new method of administration of the substance from their own experience. This method has a name, which is a certain setting. Here, this is a table where you have the two types of LSD-assisted therapies that coexisted in the 60s, 70s in the new form of therapy, which I call psychedelic, but it's with certain setting. You look at the state of mind of the patient, inform him on the expected effects. It's not the case in other psychotherapies. They create a trust relationship with a subject. And this is the idea of set. Then they organize the room so that it looks more like your living room rather than a hospital room, which is anxiety creating. So the setting is important. So there's a new attitude of the medical personnel, medical staff. You recommend to physically accompany the patients, take their hands, caress their hair, hold them in your arms to reassure them if needed. So on the contrary, in the traditional therapies, you take LSD as a traditional medicine, so you don't worry about the well-being of the patient, on the setting, on the room, or the attitude of the medical staff. Then the patient is often left alone in the traditional therapy, and touching is taboo. So you're not in contact with a patient. At that time, some psychiatrists refuse to shake hands with a patient, to say hello to, so that there is no, to avoid the transfer, to hurt the transfer process. Here, you have the major figures of this period of the set and setting concept throughout the world, except in France, where this technique was not adopted. Betty Eisner and Timothy Leary in the States, Joyce Martin in England, Abraham Hofer in Canada, Hans-Karl Lerner in Germany, Stanislas Stor in Czechoslovakia, and Jan Bastian in the Netherlands. There are other practitioners throughout the world, in Japan, Africa, etc. Concretely, what was the therapeutic approach? For example, there are 3 types of sessions. The first, preparation, where the practitioner reassures the patient, gets to know them. Then you have the session with a medication and other sessions for integration. So the patient does what he wants. He can stay, he can do activities or talk to the persons around, but it's not the practitioner who leads the experience. Some doctors used masks or here a towel to cover the eyes during the experiment. For more introspection, you can have music. As you can see on the image, the practitioner has a reassuring attitude if needed and encourages the patient not to resist to the effects or to the memories that will emerge. There are 2 models of psychotherapy. We mentioned that earlier, the psycholytic therapy and psychedelic therapy. For the first one, the idea is to give growing doses until you reach average doses, never high doses, to accelerate psychotherapy. It was used in Europe. The psychedelic therapy rests on 1 to 3 sessions with very high doses to create an intense experience. And this was used mostly in the States. The intense experience must be a source of change of personality with a renewal of the vision of self and the world. In France, again, this was not used at all. The French doctors kept the shock therapies when they used LSD, and they did not use the set and setting. Finally, these new proposals, especially in Anglo-Saxon world, are not generally adopted because the methods were not really described in the scientific literature. The teams who wanted to use LSD had to start from scratch again, and by trial and error, they drew up their own protocol, sometimes set and setting or other. There were financial constraints. This is the photograph of a psychiatric hospital in Lyon at the end of World War II. You see that it's overpopulated. There are very low funds, sometimes a single doctor for hundreds of patients. So how can you imagine to organize one in a separate room with 1 patient, with a doctor permanently with him for several hours? You realize that in our current conditions, it would be very difficult. So at the time, it was even more difficult. Then there was some reluctance because these new proposals went back to psychiatry. For example, the gender norms. On the right, the psychiatrists, mostly men, had to have a role, had to be firm in front of suffering. On the contrary, the nurses, as women, had a more natural woman to be motherhood, to more support. Here, you see that the psychiatrist is standing up, and then the nurse next to the patient can be in physical contact with him. So these norms, whether hierarchy, were very difficult to transgress. After the 60s, the scientific paradigm is changing. There is a scandal of thalidomide. So there are new assessments and safety standards. The norms are still around today. And this is always crucial in the assessment of the efficiency of psychedelics. You cannot assess LSD according to these new norms because LSD is not only a drug, medication, it can accelerate psychotherapy. And to get all the benefits, we need a lot of extra pharmacological data. And you cannot study that versus placebo because the doctors and the patients will know who took the substance or not. So in the 60s, the teams who were trying to assess LSD with these new standards could not obtain the positive results that were presented by the teams which were using the set and setting. On the contrary, the results were poor so all this with a moral condemnation in the US because of counterculture use. So the studies with set and setting are less and less credible, and practitioners that do this psychotherapy are more and more stigmatized. At the beginning of the 70s, LSD is classified in the list of drugs with no therapeutic interest. And now, in the past 10 years, studies are resuming throughout the world with neuroscience data showing the importance of extra pharmacological factors in the psychedelic experience. So the set and setting techniques are now becoming legitimate again. Set and setting is now an integral part of psychedelics. There is music, there is support from the practitioner, but as many actors are concerned more and more, the question is still who is that therapy accessible to if they're efficient. The current system is not ready to generalize this treatment in the States or in France, of course. So what will happen in the next few years? Will there be private clinics where a wealthy elite can be treated with these substances? Or will there be a change in the practice? These are major challenges that will have to be decided in the coming years. And before I conclude, of course, unfortunately, there is not much literature in French, and you will find a lot of Anglo-American literature. Thank you for your attention. I take this opportunity to say that what you were talking about, set and setting, is in the small booklet that I made available to you, which is here. There's one on each side. You did write a paper in it. So please help yourself. This is dedicated to psychedelic substances in the field of addictology. It's available to you here and there. And if you have questions, I'm sure Zoe will be very happy to answer. And if it's not the case, is it free? The questions of the booklet. It's me again. Very nice presentation. I wanted to ask you, that's how about hypnosis in the use of psychedelics? I don't have the answer. Hypnosis, I don't know. There were some clinical trials in the 60s, LSD plus hypnosis. There is some literature on it, but I cannot tell you anymore. No, I don't have any information. What do you think about it? As a historian, this is not my field of research, so I don't know. I wouldn't dare talk about it. I don't have any knowledge of it. Maybe Stanislas Grof talks about it. I see that Alex Alex can show the book. It was, he had a passion for all these questions. So I'm sure he knows about spiritual practices and psychedelics. When psychedelics started being prohibited, we tried to develop techniques without psychedelics to reach that type of consciousness. Stanislas developed holotropic therapy with breathing system with color glasses. They were developed to get around this prohibition. I have a question. You talked about the development of psychotherapies in certain setting, which requires a lot of time. At the same time, when we look at the data on the potential efficiency on anxiety with a limited number of sessions, are there any analysis of the economic cost or the gain to justify the deployment, the implementation of this type of psychotherapies? No. But some pharmaceutical labs are working on it to create private clinics where people with means can have an experience. So a business model is being created. It's like since it's funded by the public sector, if you can show that there is a benefit in a short time, so you can make things move. This will happen in the next few years. I have no knowledge of any studies, but it's becoming a major stake in the state, so there will be something happening. I think that the future is in group sessions. This is why I asked the question to Matthew Johnson, because he underlined the question of cost, because to mobilize one room for one patient for 4 to 6 hours and 2 practitioners, you have so many patients, it's not possible.
I was just curious, you just talked about any potential barriers to scaling up treatment for this. You said that the pharmaceutical companies are becoming interested in developing some business model. We've seen with ibogaine, which has been very successful, and there has been more or less prohibition or resistance around rolling out ibogaine treatment. Have you experienced anything similar to this with your work, or will your work actually help get ibogaine on the fast track to help people?
On n'en est pas encore là en France.
We're not at that stage yet in France. There is an interest in teams to start clinical trials with psilocybin and with LSD. Ibogaine, as far as I know, was not considered in addictology in France yet. I may be wrong. And when the clinical trials start, I think it can open the door for trials on other substances like libogaine. There are treatment centers with treatment with ibogaine. It's very expensive. Thank you for the question anyway. I would like to react to hypnolytic therapy. It's more in the preparation stage. You can work on how patient can be in a hypnotic state, and then in the product session to accompany the patient with hypnosis. But it's more an experience that he talks about in his bibliography. In group therapy, there are two types. Group therapy with an interaction with a patient and see what we can create from a systemic point of view. And there's another type, a psychomade psychotherapy, where you say, we're going to give doses to several patients at the same time. In Brazil, they did that because it was less expensive and the patients could live their sessions independently from each other. And then there was an integration phase. I think that the Swiss psychiatrist working on LSD in his practice, Peter Gasser in Switzerland, since 2014, he can reuse LSD in his practice with patients, terminal cancer patients, with group therapy. I take this opportunity to introduce Alexandre Perret, the coordinator of the Psychedelic Society in Bordeaux, representing the Southwest region. So I encourage you to get in touch with him. I think that if you tie the patients to their beds, you can do that with a great number of people at the same time. So I started with the clinic of self-support of cannabis. Didn't work well on the last day because it's not taken into account. I react on Zoe's talk on set and setting, which stopped in the 60s, except that after self-support was resumed and festive self-support on anxiety and treatment of anxiety with set and setting in the chill out of Technoplus, where we continued that practice, we developed a form of clinic with set and setting because we don't have any other tool. We're not doctors, we're not psychiatrists, but we use all this study and we created practices around that. And again, I'm surprised I don't see that in the current debate, like in cannabis, with hundreds, all the self-support cases we dealt with the computational cannabis experience in Switzerland. We have hundreds of thousands of cases that are not looked at because it's not part of the French academic research. So you get rid of self-support, and I think we're doing the same thing with the psychedelics, and it's a problem. I don't think it's the fashion. I think it's important to personalize medicine, especially when you talk about phytotherapy and when you work with psychedelics and cannabis on phyto that should trigger endo, and then you have to personalize. That's our experience as distributors to manage this material. We distributed cannabis, and for psychedelics, we manage the takes. But it's self-support, and I have the feel that experience on cannabis and psychedelics is taken into account by the current research. No, I don't agree with you, and maybe you'll be happy, because at the French Psychedelic Society, we have self-support groups for users with difficult experiences. So with the COVID conditions, with small groups, with confidentiality, with sharing experience between users, we can feel a need which is not yet taken into account in a formal way. The title of the session is Psychedelics in mental health, and all the presentations concern clinical trials. But yes, you are right, and this is not shown in the US presentations. It looks like psychedelic research is emerging from nothing, but it's because there are people like you or in the state underground practitioners that maintained, that did work taking risks, and then maintained psychotherapy with psychedelics that today we can can work on it today because we have all this knowledge that was overlooked by the official medicine. So you are right. It's because of these practitioners and these field professionals that maintained knowledge on this setting that there is such a rapid rebirth because the know-how was maintained by people like you. There is still one presentation. Christian Sueur. Thank you, Zoe. We can give you a round of applause, and I'm sure that we have time to work to continue discussion. And now Christian Sueur is going to tell us about the different theoretical clinical orientations in the first psychedelic therapies. Thank you for inviting me. This is the second time I come. Since the last session 3 years ago. At the last session, we were able to talk about what seems very important or necessary. It's self-experience of psychedelics by practitioners who can do something with it. So I will go against, I will not agree with the current thinking. We're not against pharmacology, neurobiology, techniques and methods, because I practice that too. But there are more psychodynamic notions, individual notions, or even philosophical concepts about the practice and reflection on these substances. In the last century, we said that it was important to say where you spoke from. As Laurent was saying, I started being interested in LSD in the late 70s. I consumed scientific consumption of LSD. I became a psychiatrist. My first job in a review, a psychiatric review in '88. It was a historical work comparing 1 century apart what the cannabis consumption was, and with LSD after the war, how the psychiatrists with LSD were able to continue thinking about mental health or making progress in mental health. And the link with mental health, etc. 10 years later, with Bertrand and other colleagues, with Technoplus, with a self-support group in festive environments, we started thinking about implementing harm reduction strategy in techno festive events. I hired 6 ethnologists to do this job, to analyze the products, in chill outs, to accompany the people in the chill out rooms, and to ask questions about what was this collective phenomenon, what relationship with shamanism, etc. So this takes this takes us to the group. My presentation is much longer, and it will be. I will have to shorten it. That's my destiny. So we will stop. You will stop me as usual. So I'm a psychiatrist, addictologist. So I've been interested in psychedelics for more than 45 years. So with the president of the GREC group, we have a website, grec.org, with thousands of articles on cannabis and therapeutical subjects, and hundreds of articles on psychedelic therapies. So if you see documentation, you go down, and on the smartphone it doesn't work, but on a computer, documents, and you see psychedelic therapies. You have 5 minutes left. So you will have in all the articles mentioned, those that I could mention. So my paper will be in line because I will only have the introduction today. So let me start. Slide number 1 is here. No, it's not there. It's on the right. It goes way too fast. In a review, in the 50s and 60s, there was no concept of psychedelic therapy. Therapy are closely linked to the administration of LSD and mescaline. It's either clinical observations, like in the French psychiatrist hospitals, on what is considered as psychotic steps, or there is psychotherapy with LSD. That was before the other psychedelic substances. We were talking at the time LSD therapy, but mostly LSD psychotherapy. There are historical articles in the States, Germany, etc. We can also mention in 1959 the use of hallucinogenic agent in psychiatry by Oscar Jeniker. And the role of psychotropic drug in individual therapy. These are LSD therapies. And then psychotherapy in all the articles becomes widely used in the 70s. Sanderson, Baker in Toronto, Sweden, Gordon Johnson, a whole lot of references. I have a lot of documents on the subject. We have thousands of articles in the past 45 years on holistic psychotherapies. For instance, in 65, by Ludwig and Levin, a controlled comparison of 5 brief treatments techniques employing LSD, hypnosis, and psychotherapy. So a reference on hypnosis. And then we start looking at what you treat. So neurosis, and then we go to depression, and then we start, depending on the subjects, with a group of syndromes. The president of the Dutch psychanalysis is going to treat victims of Shoah in the 50s with LSD. So he's going to work on the post-traumatic effect. So this is very interesting to to read today all this documentation.
Plus loin justement que des méthodologies qui vont sur le comportement, sur l'effet de la substance et qui sont avec des choses très importantes, hein, le coût économique des traitements. Enfin, c'est pas avec ça qu'on soigne. Alors, donc, à la fin des années, enfin au début des années 70, voilà, c'est la période où on dirait tout s'arrête et les choses vont reprendre. Alors, il y a eu des thérapies qui ont continué de manière occulte, surtout aux États-Unis. Il y a un exemple en Suisse, hein, Peter Gasser et ses quelques collègues ont continué de 88 à 93 à faire des thérapies au LSD et avec le LSD et la MDMA pour des fins de vie, pour des dépressions. Et puis, pendant ce temps-là, c'est plus les pharmacologues qui travaillent. Hein, Shulgin, sur la synthèse de toutes les 128 ou 135, je ne sais plus, phényléthylamines qu'il décrit dans Pical, 250 tryptamines, dans Tical, les tryptamines que j'ai connues et aimées, etc., Nichols et autres. Donc, ce qui est intéressant, c'est effectivement, c'est en 1994 que Charles Grob, il a été évoqué tout à l'heure sur un travail avec la psilocybine de 2010, et Charles Grob a été le premier aux États-Unis en 1994 à avoir l'autorisation de réutiliser le LSD et la MDMA pour traiter les fins de vie, pour accompagner les fins de vie.
End of life. And to treat addiction as well. This is something that we discovered when I was working with Médecins du Monde. And he also was with a number of programs of harm reduction. And he started using that in the practice as well. He proposed me to join UCLA. Maybe I should have joined. I would have been a practitioner at UCLA. But that was not the case. I continued to work on harm reduction. And again, helping patients in reducing their burden. Of course, we need to have a sound knowledge of pharmacology, neurobiology as well, of those different substances. This remains for me fundamental, that I was able to experiment that, to see what are the effects, and also, again, have this first-hand experience, I think, is important. And what I was supposed to talk about was the different concepts that come from meta-psychology, from Freud and Jung, and the transpersonal analysis as well. The work by Maslow and Groff as well, and transpersonal psychotherapy. And it's interesting to be interested in shamanic works. I'm going again to move very quickly. There were other things that I wanted to say, but in the interest of time, I'm just going to skip that. Now, at the end of the 50s, we see the term psychedelic therapy. This is a term which is being coined. This was shown previously. Zoe showed a very nice presentation on psycholytic therapies. Sandison and Loda in Germany, they would use low doses that would be supporting psychotherapy. Now, in psychedelic therapy, dose is going to create a peak, and the experience, it's really the experience itself of intoxication is going to produce effects, and at the center you have the mystical experience. Hence the interest of what either Dr. Johnson or Dr. GARCIA-ROMEU mentioned. You need to make the difference with the religious effect. So we also had experiences with religious people psychedelic drugs, and there's a difference the spiritual process in which those religious people are. You have the Good Friday experience, of those Good Friday experiences that are very interesting. Back in those days, Walter Pankow was a student in theology at Harvard, and Timothy Leary was his next door neighbor. And they would conduct experiments with the students in theology. So they gave them LSD. That took place on Good Friday, hence the name Good Friday experiment. And then 20 years later, there was, I think, another study. There's, I think, even a PhD work, a follow-up study of those theologians. They are now ministers, Protestant. And they wanted to measure 20 years later how the experience, or how this experiment of the Good Friday had an impact on the way they, on their religious experience, so to speak. Those different experiments in this period, I've also had a number of follow-up studies. And what we had was the synaptogenesis that was mentioned, the different mediated phenomena were continued to be observed and measured. Now, we of course have a biologic basis, but this experiment had long-term effects on the synapses and on the way the patient is in the world. So the patient was treated, and we talked about the theology student who experimented a change in the way they lived their faith, and potentially the ability to be a practitioner. So this is what we had as well. We were not in those days. We were not psychologists. We were not educators. We didn't have a good knowledge of those products, but by working with that group of self-support, we would be sharing experiences. And we would use music, we would use lights, and we would create a space to create some relief and to soothe the people. So you have LSD psychotherapy in 1980, published by Growth. And 1980 is more or less the milestone, the date when we stopped those experiments. Before there was this psychedelic renaissance, as we called it, on those aspects, to try and see how those products were discovered. And I know that there were also a number of studies in pharmacology. One of the speakers mentioned those. And after that, there was also a review of different papers and the way we can. There are PhD studies now on the history on that, and there was also studies on traditional use, shamanic use. So as I said, 1994 at UCLA, Charles Grubb picks up that, and then it sort of spreads, and there's more and more interest. You have a number of treatment of different editions in St. Petersburg. The publications do not meet the criteria of the different publishers, so unfortunately we do not have much access to those studies. Didier Raoult has a methodology which is different. Today, you have a doctrine which is such that you need to comply with a number of criteria, and if you don't, then you do not have access to this literature, and that's a shame, but that was an aside. Sanderson in 55 have an experiment with low doses above 30 milligrams. And that's very interesting because microdoses, as Laurent said previously, same thing as with cannabis. I fully agree with you. There's self-therapy. And of course, you need to be supported by a general practitioner, with users, by peers as well. But it is possible that you help yourself, so to speak, that you find a way to be an actor in your treatment with low doses of psychedelic drugs. This is LSD and psilocybine. Mainly, Sanderson was involved in mental health, depression, and Sanderson traveled to Basel in Switzerland. He visited the Sanders lab, found that lab very interesting. Then he came back to Switzerland to pick up his own stocks of drugs, of that drug to treat his patients. And what he said, patients that are not treated in a satisfactory fashion by conventional psychotherapy can be helped. Sanderson was more a proponent on Jung than Freud, but he had resistant patients, resistant to treatment. And so with LSD, Sanders LSD, he has that drug which helps removing resistance. So you have unconscious that becomes accessible. You can dissociate the reason of anxiety. Memories are back to memories are back with all the angst and horror of the initial situation. For example, in case of rape or in case of war crimes or PTSD, etc. So everything comes back to memory. But the trauma is back again, and so there's yet another trauma. But with the substance, you have the memory without the trauma. So it's when you send an email, you may have attached documents, and in that case, you can detach the document. So you have less anxiety connected to the fact that you relieve that memory, and so you can work on memories. And it's very interesting from a psychotherapeutic point of view. You can put that in connection with death, your connection to your father, your mother, and everything that Freud is talking about, etc., etc., etc. It's very difficult to translate. I apologize for that. And is reading a paper, and we don't even have the paper anyway. So that's really make for a very difficult translation. Hans Carl Lohner is not a conventional psycho practitioner, symbolism in dream, and he developed a method with his patient with LSD at the end of the 1960s, the guided affective imagery. So you have Bastian in the Netherlands. I'm not going to talk about the French school because there were very few treatments. And then you have the American school. The predecessor of Grof, when Grof immigrates from Czech Republic, and again he settles in Baltimore with others, with a group of others, and Charles Sabat was cited, Gary Fisher, Albert Kurland. They are around Stanislas Grof, and you have a number of interesting references with cancer patients as well. Now, what's interesting in literature there's a synthesis or review work. You have the book references here. LADIC in Canada in 2008. This is before the psychedelic renaissance. In medical literature, you have all those issues that become topical again and very fashionable. And so a number of things that we had summarized in 1999. So Chambon publishes in 2009, Ben Sessa in London with LSD, with a team of the London Imperial College, and then other books of more or less interest, Miller, Oram, to name but a few. There are many books, and if it's of interest to you, you have that in your slideshow. Can I talk about growth if I have 1 or 2 more minutes? With Maslow, he created a theory of transpersonal treatment. So it's at the crossroad of different therapies. So Maslow was the co-founder of humanist psychology. Also a technique of hyperventilation, which is used in the same line as rebirth or meditation. So you have the modified state of consciousness. It's the same thing as Ericksonian hypnosis or in the psychotherapy. It takes you back in an atmosphere where the practitioner helps and support. Then fourth wave, the behavior cognitive approach, which is very prevalent at the moment, and I'm very sorry about that, by the way. And then the humanistic trend, existentialism, so a current or a trend which is very present in Germany, in Holland, or in Latin countries. So, there's Jung, but many others, existentialists. So in connection with memories and the different trauma of birth, but mostly focusing on trauma and how you can manage trauma. And early trauma that we have all the time when we have patients with addiction. The question of trauma is always of interest in that type of therapy. There is an irresistible pain provoked by that type of trauma, and this, of course, is a trend of its own. So it's different from Jung, it's different from Freud. And this meta psychology is really it leverages the learnings of different traditions as well, Western, Eastern, but shamanic work as well. You also have so this is this transpersonal therapy, the transpersonal approach. It is a new way, it's a new paradigm with a spiritual dimension. This was very different. I'm sorry, I cannot see how much time is left. Okay, 5 seconds. Oh, 5 seconds. Okay. Anyway, so we saw with our 2 American colleagues from the Johns Hopkins Baltimore Center, And depending on the experience that they had in their youth, plus there's a connection with a traditional approach like shamanism and a more spiritual approach, but it's still very... So I'm going to conclude. I've reached the last page of my long presentation, and you will find that potentially on the dark web. I'm going to talk in particular about a paper by Scott Hill on the psychedelic experience, steps toward psychedelic humanity. We see that young psychoanalysis is of interest to some. So, I'm sorry, it's really, really difficult to translate. So you see quite a number of texts of Jung's that were recently republished on Jung's therapy. And you have interesting excerpts from his own journal. And when you read the Red Book by Jung, you have a good overview of what was experienced by the different patients. Well, I think I have no excuse, and I need to conclude now. So I also worked quite a bit on mystical experience, but I don't have enough time. Too bad. Thomas Roberts, Wilton Mann, Richards, etc. Have very interesting contribution. They're not very well known here on the other side of the ocean, and that's a shame. And what I want to conclude is it is very important to have psychotherapy in those patients, because drugs are not enough. As a specialist of Peter Webster is a specialist of psychedelics. Very few know him. He's a chemist, and there's an interesting experiment from him. There's a book by him named Cosmos, and I think it is very important to read that book. The fact that the certain setting is not sufficient. Albert Hoffman himself, in the experiments on himself, said, well, be careful, there's something devilish. I think you started your presentation with an angel and a devil, right? And indeed, you need a guide. The practitioner needs to be trained, because the mythical experience can be dreadful, and you need to be supported, and you need to have the right practitioner, and that's interesting. There are very recent works that were published recently to come back to the different psychosis and how it can be used in therapy. And I think there's a lot more self-support by associations. Association can help those individuals with a negative experience with those drugs, and sometimes there's too much of the modern positivism. They do not see they do see the difference in between a number of medicines. They see the difference between LSD and selective inhibitor of serotonin recapture, but I think they would not be helpful for individuals with a bad trip with that. But now today, you prescribe Ritalin to young children, hence the interest of using CBD instead. But anyways, that was more or less what I wanted to say. We need to be inspired by the shaman experience. And you have different points of view, of course, on this. You can be inspired by self-support, because myself, as a psychiatrist, I do not try to cancel out the negative experience of my patient. The negative experience is necessary to activate a way to find a solution and find a cure. So substance is not enough. And what is very interesting with MDMA, it was not discussed, but with MDMA, you have different levels at which you can intervene. Dawson Passy, for example, wrote on group psychotherapy assisted with MDMA in the case of trauma. Cannabis and MDMA are very interested for psychotraumatism with a reasonable. So you need to use psilocybine or LSD, so those different substances or interests before and after. And I think that you're going to turn off my microphone. There's a paper in Brain. I'm sorry, this is really impossible to translate. This gentleman has no interest in the public and disseminating anything at all. I'm sorry, this is really impossible. Okay, thank you very much, and again, apologies from the interpreter. I really apologize for that.
Before the conclusion by our president, I would like to wrap up to say what could be the future. But I promise it won't take more than 2 hours. Thank you all for coming. Thank you for your questions. Thank the speakers.